The following PSA is brought to you by UNC Health Nash, Boyce Willis Clinic, Primary Care Urgent Care, and WHIG TV. According to U.S. breast cancer statistics, 1 in 8 U.S. women will be diagnosed with invasive breast cancer in their lifetime. In 2025, an estimated 281,550 new cases of invasive breast cancer are expected to be diagnosed in women in the U.S., along with 49,290 new cases of non-invasive breast cancer. Early detection saves lives. Survivors know the importance of detecting it and treating it so you can defeat it. It's a journey that requires tremendous support. When was your last checkup? Beat the odds with regular checkups planned by you and your provider. Detect it, treat it, defeat it.
Hello, welcome. This is Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center here in town and the owner and operator of the Essential Health Medi-Spa. Tonight is I consider her a good friend. We met each other last year and we've clicked and everything went well, and so anyway, her name is Ranju Singh, and she is a nurse practitioner. Of course, you know, nurse practitioners rock. I just want you all to know that. And she works at the UNC Nash Cancer Center, so she's going to tell us everything we need to know about breast cancer, right?
Yes. You got it. Thank you, Linda. That was good. Yes. And I am glad to call you my friend too. So yes, my name is Ranju Singh. I work at UNC Nash Cancer Center, and I'm a nurse practitioner, as Linda said, and I see general oncology patients. We also see some hematology patients too. Yes, so UNC Nash Cancer Center serves population here in this Rocky Mount area. We also have patients from Tarboro, like close to like 100 miles around this area.
Because it's closer here than other places, yeah.
At UNC Nash, we have total 5 providers. 2 are full-time medical oncologists, board certified. 2 nurse practitioners, Bridget and I am there. Bridget is also palliative care, NP. And then 1 provider who is locum, and we are looking for our 3rd oncologist.
So if you know of a good oncologist, tell them how great Rocky Mount is and send them this way. That's exactly right.
Yeah.
Or if you know any good primary care providers, we'll take one of those too.
Yes, send them to her way.
That's right. Yep.
So yes.
How long have you been there now, Ranju?
So it has been close to 2 years now. So yeah, 2 years, and I live almost 80 miles from this place. Right. And initially I was kind of how long I'm going to drive, but I enjoy working with people here. So I am glad that I'm here, and it's something which I'm very passionate about doing. So yes,
I think that's one thing, you know, if you're passionate, I'm passionate about, you know, family medical and family health, and I'm passionate about good health, healthy eating, exercise, and we're going to talk about that at some point, because I think that has a lot to do with prior to cancer diagnosis, and I know it has a lot to do with post-cancer diagnosis.
I totally agree with you. Yes, I completely agree with this. I have noticed that patients who get, or people who get diagnosed with breast cancer, if they are good, if their health is good at baseline, they tend to do better during their treatment. They do better after their surgery. They tolerate chemo better, and post-recovery is also better for them. Toxicities are less, and after the treatment also they handle things well. So yes, good health, good nutrition is very important.
Absolutely.
Yeah.
And that's whether you are diabetic, have cancer, or just want to stay healthy and have a great life. You know, I've got an 87-year-old, and her husband walk every day. She's of a good weight. She's not overweight, and she does not have one health problem. I see her every 6 months just to see her. You know, she doesn't even take a blood pressure pill. Isn't that awesome?
Yeah,
so
it is awesome.
Can be, and part of that I'm sure is genes, you know, as well.
Of course, yeah.
But she works hard on taking care of herself.
Yes.
So, so we're going to talk about breast cancer. So, when a person is diagnosed at the breast care center, then do you know how that whole procedure works? How they get from the breast care center to surgery to you?
So,
do you know that route?
yes. So once we get referral for these patients at our place, most of the time they have already a diagnosed breast cancer, right? And at least biopsy is done for them. After that, when we receive them, we go through the biopsy results, and then we decide which route this patient is going to go. As you know that for women, the journey of breast cancer treatment is different for different women. I think there is this misconception in general population that if you get diagnosed with breast cancer, everyone gets the same treatment. No. It's not like that. It is very different. Your cancer journey, breast cancer journey, depends on the kind of the stage, the kind of breast cancer you have, and how involved it is. And so yes, and we run several tests to find out if it is hormone positive or if they're HER2 positive. If your treatment is going to be just for couple of months or couple of years, or you are someone who is going to get treatment for the rest of your life, which happens in stage 4 too. And then also, if you are if you have hormone positive breast cancer, if you're going to get anti-hormone therapy for 5 years, some gets tamoxifen 10 years. So every patient's journey is different.
Because there's multiple different cancers, of course.
Yes.
It's not cancer is a group word for lots of different, and I don't know any off the top of my head. I'm not very well versed in cancer actually, but you know, like you said, there's the HER2, and what else did you
so we have hormone positive. It can be estrogen receptor positive, or progesterone receptor positive, or if somebody has HER2 extra gene, that can extra copy, that can also drive their treatment.
Right.
So,
And that you determine that by biopsy?
Yeah, so we need to have tissue sample for running those. We don't run those on the blood test. So yes, we need to have those. But yes, first thing is every woman should get screened.
Yes.
I know that recommendation is like 40 years and above, but I think if you have family history of breast cancer, getting screened earlier is not a bad idea.
Right, and most insurances, if you have that, if mom had breast cancer, grandma and aunt have breast cancer, I think you can get a mammogram earlier.
Yes.
I don't think there's a die-hard fast rule. I think everything, you know, every situation is looked at. But I you know, because when I do a physical, I'll say, "Oh, you're 38. You don't need a mammogram yet." So, "Oh, I've already had 2." You know, because of
based on their
previous history or their family history. So, I mean, I'm grateful for that. Because I would not want mom and sister to have had breast cancer and have to wait till I'm 40 to see if I've got it.
Yes, and also there is this misconception or myth among a population that you only get breast cancer if you have a family history of breast cancer. However, that is not true. Only 15, like approximately 15% of newly diagnosed breast cancer patients have family history. Remaining 85% are like they don't have any family member or family history. So every woman are at risk. 1 out of 8 women in the United States are at lifetime risk for developing breast cancer, invasive breast cancer. So
1 in what? How many?
1 in 8. So 13%. Yeah.
It used to be 1 in 10.
Yes, it used to be 1 in 10 couple years, some years back. But yes, breast cancer among women are increasing, and younger women specifically. And I think there are several reasons, factors for that. Women are having kids at a later age, and also lifestyle and stress. So I think all these are environmental factors too. I would say we have so much, I would say, carcinogenic substances in everything, in our food, in our water, so who knows, right?
I know, I know.
Yeah.
My husband gets mad at me. I'll say, no, you can't buy that candle. It's got to be soy or beeswax, because they don't emit carcinogens. He's like, oh, Linda.
Yeah.
Sorry.
Yeah.
I mean, I try to be cognizant
Yeah.
about that. You know, I try not to use like poisons even in my garden. You know,
That's good.
I use peppermint oil and things like, and natural things to get rid of the bugs.
Yeah, that's true. Pesticides and certain chemicals are predisposing you to cancer, and there are there are some myths around like dietary thing too, that if you are healthy and you are eating all like organic food or eating only healthy, then you are not at risk of developing breast cancer. That is also not true. You can get, however, if you are someone who is following good dietary practices, you do have better chances of not getting it, and of course better recovery. If you get treatment, you will do better during the treatment. So yes, all those facts are true.
Yeah. Well, and some women don't want to have a mammogram. They'll have it one time. It hurt. I'm not going to do it again. And what would you say to those women?
So I think getting a mammogram is not a painful procedure. Okay?
No,
and I can say that personally. However, if you are someone who's getting a mammogram done when you are around your period, so like a couple days before or around your period, yes, our breasts are tender around those days. So getting compressed in a machine for the x-rays can be painful. If you are someone who is on certain medications which can cause breast pain, and then you go through the mammogram, that can be painful. But yes, I advise my patients that if you have to get a mammogram done, do it at least like 10 days, 1 week or 10 days after your period. So that way it is, and also certain medications can cause, so keep that in mind too. But yes, if you see risk versus benefit, I think the benefit is far more than the risk of or going through that pain. So yeah.
Yes, I know. You know, it's really difficult to convince some people. They have it in their mind and they're set, and all you can do is offer and say, well, you know, if you were my mom, this is what I would recommend.
Yes,
if you were my sister, I do it myself. You know, that's all you can say.
I agree. Same thing. What I would do for myself, or what I would suggest my sister or my mother or my family member, the same suggestion I provide them. But again, people have that choice to advocate for themselves. If they don't want to get it done, we cannot twist their arm to get it done, right?
No.
Yeah.
Do you see, do you have any male patients that have breast cancer? I know it's rare, but there is that possibility.
Yes, so we do see, I know I know you are already aware that of all the breast cancer, only less than 1% are male patients with breast cancer. But yes, male can get breast cancer because they have breast tissue, and most of the time they are the one who are diagnosed late. But yes, and it is more common in black men than white men, and men with BRCA1 mutation has more, they are more prone for breast cancer than BRCA2 or no mutation.
Yeah, that's the BRCA1 and the BRCA2.
Yes,
I want to talk about that a little bit when we come back. But it's time for our first break. I can't believe it already.
Yes.
Thought I was watching the time. I'm poking my phone, looking at the time. But anyway, Lee gave me the finger. You know, he comes and goes 1. That means 1 minute. So we will be right back after you watch these sponsors, and we'll talk more to Ranju about breast cancer, good health, how to take care of ourselves, and everything in between. So don't go away. We'll be right back.
The following PSA is brought to you by UNC Health Nash, Boyce Willis Clinic, Primary Care Urgent Care, and WHIG TV. According to U.S. breast cancer statistics, 1 in 8 U.S. women will be diagnosed with invasive breast cancer in their lifetime. In 2025, an estimated 281,550 new cases of invasive breast cancer are expected to be diagnosed in women in the U.S., along with 49,290 new cases of non-invasive breast cancer. Early detection saves lives. Survivors know the importance of detecting it and treating it so you can defeat it. It's a journey that requires tremendous support. When was your last checkup? Beat the odds with regular checkups planned by you and your provider. Detect it, treat it, defeat it.
When Jay arrived at the emergency department with a hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough. I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't rise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
What is Celebrate Recovery? It's a Christ-centered, faith-based recovery program for anyone dealing with life's hurts, habits, and hang-ups. Celebrate Recovery meets every Thursday night at 7 p.m. at Farmington Heights Church in the Wilson, Raleigh, and surrounding areas. Please join us every Thursday night at 7 p.m.
Hello, welcome. This is Here's to Your Good Health. If you think we've moved around a little bit, you're absolutely right.
We did.
We wanted to make sure that all of our sponsors were seen. It's very important that you know, they are such an integral part of our TV community and our community as a whole, and so we wanted to recognize them and make sure that everybody knows that these particular businesses are all about taking care of our community. So we want, and you know, I'm all about community. You know that. Anybody that's watched me for a while knows that I'm all about community and all about working together and living together. So, all right, we're going to talk a little bit about risk factors. So what are some of the risk factors of breast cancer?
Great. So yes, our biggest risk factor is our sex. We are women. True, being a woman puts you at the risk of breast cancer.
Right.
And also aging. Growing old is good. It's a privilege. Not everyone gets to grow old.
That's right.
We are getting to grow old, but then also getting old is increasing your chances for breast cancer. And then certain genetic factors. There are several, but like BRCA1 and BRCA1 and BRCA2 are the some well known. And then also lifestyle, like certain lifestyle, I would say, like increased body weight, obesity, excessive alcohol consumption, stressful life, those put you at risk. And then, of course, family history plays a role in your breast cancer diagnosis. So there are several, but these are some very common risk factors.
Right.
Yeah.
So we can't change the fact that we're women.
We cannot. We have to just live with it. Yeah. Yeah.
And so we can't change that risk factor. We can change the obesity.
We can, yeah. I mean, we can reduce it, yeah, but work on it, yeah.
Right.
Yeah.
And of course,
lifestyle.
You know, lifestyle and you know, cooking yourself and chopping those vegetables yourself instead of running through the drive-through and getting a burger and fries.
Agree, you got it.
I know, and I, you know, I'll get a burger every once in a while. I get a hankering for one. I gotta have one.
Yeah.
And sometimes I cook them at home, and sometimes, depending upon my schedule, I might run through. But you know, if I do that once every 2 months, that's about it. You know, we can't do that even weekly.
Some of the stuff which we can do to reduce some of these risks is, of course, cutting down on your unhealthy lifestyle or practices, like less alcohol. If you're a smoker, smoke less. If you are eating lots of processed food or red meat, reduce that. That can help you. And staying healthy overall is the mantra. So, and yes, getting mammogram screening done. Yes, yes, it is true. There is myth that mammogram doesn't catch breast cancer all the time, and that is true, not all the time, but majority of the time it would. And doing self breast exam at least once a month when you're in the shower, and 1 week after your periods are over, then you can do self-examine yourself. And yes, some patients, I have heard from patients that I never felt a lump, and my mammogram was negative some months back, and I still got this breast cancer. So that can also happen. But yes, the key is to catch it early. The key is to catch it early, and if we catch it early before it has spread to other parts or other spread to lymph nodes, the chances of recovery and your cure is better. So, yeah, that's the main.
Yes, and when you do your self exams, do not do it around your cycle, because we tend to get a little lumpy then.
Yes.
So we need to do it about 5-10 days afterwards, I guess.
Yes. Yeah. At least. Yeah. I would say at least a week to let that tenderness go away.
Right.
And Also, I have heard from patients that, oh my, this lymph node or this growth was painful, and I have heard that if your growth on the breast is painful, then most likely it is not a cancer. That is also not true, because you never know.
Right.
You never know. So if you have found a lump, get it checked and get it investigated. Right. See a doctor and find out if it needs to get removed or not.
Right.
Yes, there are patients who have like benign cyst, which can be there and can be painful, or some patients have mastitis due to some infection or something. Those can be painful and are not necessarily breast cancer,
right.
but getting those checked and diagnosed.
I mean, you can have an abscess too, and it can be under the skin, not necessarily over the skin, and that could be painful too. So that's why you need to see a professional and have him or her look at it and evaluate it and determine if you need that mammogram or not.
Yes. So any women who notice any change in their breast, and this change could be change in the pattern of skin, or if they have retraction of the nipple, or if there is any discharge, or if there is some soreness which doesn't have any other reasons, those should definitely get checked and investigated. Yeah.
And I'll tell you, even if you had a mammogram 6 months ago and now you've discovered something, don't think you have to wait the other 6 months. Go to your provider, have him or her examine and determine, and they'll decide if you need that other mammogram. And the one thing I'll tell you about insurance that upsets me, if you've had a mammogram and they see something and they want a follow-up, like maybe they want a diagnostic with an ultrasound.
Yes.
Insurance won't pay for it again. That I'm aware of. That's what I've been told. I haven't.
Even if they have found a suspicious.
Correct.
Okay.
Yeah,
I
and
have
so
actually not come across this.
That's most unfortunate, because someone will say, and I have no idea what a mammogram costs. I have absolutely no idea, and I don't want to know. But you know, insurance can be a deterrent. But I would say to you, if that's the case, please borrow the money from mom, dad, sister, brother, whoever. Your health is much more important than the decision of an insurance company. So that would be my.
And we also have support here at UNC Nash, where your mammogram can get covered.
Right.
So yes, do not hesitate to get your mammogram done.
That's right. Yeah. And I'll be happy to be an advocate, and I'll be happy to call the
Breast Cancer Foundation.
Right.
Yeah.
I didn't know what it was, but I could call you and find out. That's for sure. I got her number, so you know I can get to her. But anyway, I just don't let outside influences stop you from getting the best optimal care that you can get. Now, if you want a mammogram every 6 months because you're scared of it, no, that's not the same thing at all.
Yes. Another myth I have heard from patients that mammogram exposes your breast to lots of radiation, which is not true. So screening mammogram is just 2 X-rays, so it's not that bad. So I would recommend you not to worry about that radiation risk, because it's just 2 X-rays. So
and I don't know how many you have to have before it would be detrimental, but I've been around X-ray. You know, when I worked in the ER, there was X-ray machines going on all the time, and sometimes I'd get out of the room, and sometimes I wore an apron, and sometimes I didn't for whatever reason. So, you know, that you can take quite a bit of X-ray before it's going to really be detrimental to you, I think. So, any other risk factors that you can think of? That's about it.
Lifestyle, I guess, definitely. You can work on it, but there are certain risk factors which you cannot avoid, like being a woman, I would say, and having a family history.
Right.
But yes, there are more.
And are there pockets of even around here that sorry, dropped it. That you know, there's certain. Is the black population more susceptible to breast cancer? I know you said in men it is. I didn't know if it was the same for women.
So the risk for getting breast cancer is less in black women, 5% less
in black women. Okay.
Getting breast cancer is less in black women, 5% less than the white women. However, the prognosis is bad in black women.
Really?
So I think that is because, also the data supports that too, it is because of they are getting diagnosed at a later age. I mean, I don't mean later age, like later stage of the disease. And also the support system or the treatment or seeking treatment. So these are some of the factors which actually gives them bad prognosis when compared to, and also, so high risk disease in them. Yeah.
And are there, you know, like North Carolina is in the stroke belt in that we eat poorly and we don't take care of ourselves the way other parts of the country do. Are there do we have a higher population of breast cancer here than in Indiana, for instance?
So I don't have that comparison data, but I do see, I think in our clinic, I don't have the number with me, so I cannot give you the exact figure. But I think we do see more black population with breast cancer here. There could be other reasons too, that many patients who have good support system, financially better position to go to Duke or UNC Chapel Hill. But yes, I want to tell our patients that if they are going to get frontline treatment for breast cancer or second-line treatment, they can get that treatment here at UNC Nash. But yes, that could be one reason, transportation issue, that these patients are not going far and coming to us. And our cancer center is relatively new. We are only like 5 or 6 years old. It is expanding, getting bigger. I think word is going out that we have a cancer center here. So we see more. We are seeing more and more patients every year. So but
and I've said this before, but if you feel like you've got breast cancer or you want to be checked and you want to go to Duke or Chapel Hill, that's great. You have to go where you feel comfortable. You have to go where you feel you're going to get the best care. But you know that you can be seen by that group of cancer specialists in those hospitals. They can formulate a plan, decide what chemo you need or radiation or whatever the treatment is, and then that can be translated down here to the cancer center, so you don't have to go back and forth every day or 3 days a week or whatever the plan says. So you can establish yourself at Chapel Hill and they will give the treatment plan to the doctors here. So that's a real blessing for us, because you know, the thought of having to drive to Chapel Hill 5 days a week is a bit overwhelming.
Yeah, especially during radiation and all, where you have to
and you're already tired and physically weak, and then to have that hour-and-a-half drive one way, it's a bit much.
Yes, and sometimes patients don't drive. They need someone like a caregiver to take them to these visits. So yes, the beauty of UNC system is we send our patients for consultation to UNC Chapel Hill. We also send our patients to Duke too, but most of the time UNC Chapel Hill, and then they help us. As we are not the specialist, like breast cancer specialist, we are general oncology, but we do have access to the care which breast cancer specialist will provide them at Chapel Hill. So we do send them there and get their recommendation, consultation, Chapel Hill, and also at Rex. And then we can provide them same treatment here. So yes, they do get the same treatment which they would have given at they would haven't given at Rex or Chapel Hill, without making those long trips to these centers. So that is a blessing.
Really, it is. It's an absolute what's the word, opportunity, I guess, for getting top-notch care at home instead of having to go so far. So it's really,
some years back when I was working at Duke, and we had so many patients. I used to come across several patients who were traveling like 2 hours or 3 hours, driving one way to get their treatment, just like 30 minutes infusion, and they were driving back. And I used to wonder that these infusions or chemotherapy are not that hard or not that complicated that it cannot be given at local community centers. And I'm glad that I'm getting opportunity to work at a place where I get to see that, like something which I has like dreamed of or desired or wanted my patients to have. I am getting to see that here and do it here. So that is something I think I like about my job.
You like a lot about your job.
Thank you. I do.
You're very passionate about this, I can tell. I knew that last year when we talked, that, you know, it's just you kind of light up a little bit. Not that you want people to have cancer, but you want to be able to give them the best care.
Yes, and I think because I have not, one of the reasons is this is where I have seen myself always. Like, I wanted to do this, like, since the time I remember, like, even as a teenager, I knew that I wanted to care for people. I didn't know then that I will be doing oncology, but I knew this is what I wanted to do. And here I'm getting opportunity to do that. So.
Right.
Okay. So
yeah, I wanted to be a nurse since I was a little girl. You know.
did.
I did. Yeah, I did. I guess it was just inbred in me, right?
Yeah, yeah.
It's just
and
part
I
of
guess
who
that's
you
why
are.
you're still doing it and enjoying it, right?
Yeah, that's right. I do. I really love my job, and I love my patients. I do. That's what keeps me going.
I think it is so important to find your purpose and find out what you actually enjoy doing, right? I'm not saying that all days in my life or in the clinic are good days.
No.
There are bad days. There are days when I'm like not happy what I'm doing. I'm not satisfied with the kind of work I have done. But then overall, if I see the big picture, I think there's nothing else I would had enjoyed doing. So yeah, even in healthcare, I think if you put me in cardiac nursing or cardiology, I don't think I can. No disrespect to them, but I don't think I can do it. Oncology is something I think I started doing it after leaving college, and since then I'm doing it.
Well, I think, you know, I mean, we are who we are, and we have these giftings inside of us, and if, you know, somebody having cancer, you're going to deal with them emotionally differently than you would somebody that had a heart attack. You know, you just do, and you have been in this long enough to really understand the disease process, understand what they're going through as much as possible without going through it yourself, you know.
Yes.
And that's very important, to be able to empathize with them and you know, have that connection.
Yeah, some skills I think we are born with, but most of the skills which we use in our daily life are actually acquired ones. So you are right. I guess because I have stayed in this field for a long period of time and had the opportunity to acquire these skills and refine my, I would consider it a craft, right? Refine my craft. So I think that is also that has also helped me in doing what I'm doing. So
yeah, it's really interesting. So I love being a nurse. I've loved it since the day I graduated. I got a 2-year degree and then moved my way up to 4-year degree and then, you know, NP and that kind of thing. But I've always loved everything I did when I worked at the hospital. I loved that, and you know, now I love being in the clinic. And like you said, there are days, I wish I would have stayed in bed. But that's with any position and anything you do. You're going to have good days and a couple of bad days here and there.
Yeah, you have to see the big picture and the whole picture.
Right.
Yes. And in oncology, I have taken different roles. I have worked as a, I have done bedside nursing. I have been a pediatric bone marrow transplant nurse. I have worked as a CRA monitoring and a research lab manager. I have worked as a nurse consultant, research nurse coordinator. Before becoming a nurse practitioner, I have worn several hats, of course all in oncology, but in different roles.
Sure.
And if I have to compare all, like see the satisfaction of all my roles, I would say this role as a nurse practitioner, and other would be research nurse coordinator. I enjoyed clinical research too as a coordinator. So these two roles, yeah.
And are they
favorite.
still doing research over there at UNC now?
So at UNC Nash, we do not have, I would say, we do some small clinical research studies, but we don't have the big ones.
Right, of course not.
We
We're not
are
big
doing
enough
some
to
symptom
do that.
management and stuff like that, but yeah.
Okay. And what are the biggest symptoms of a client or a patient that has, let's say, is getting chemotherapy? What
So
are the
yes, so this is something I'm passionate about in my clinic. So symptom management, we do see that like 10-20 years back, breast cancer management was bringing, especially chemotherapy, radiation therapy, all these were giving lots of side effects to our patients, and that was a big, I would say, discomfort, and some patients still get PTSD when they think about those side effects. But things have changed a lot in the last 10-15 years. For example, management of nausea, right? Nausea, vomiting. We have better tools now to manage those. Some stuff we are still struggling with are long-term impact of neuropathy, nerve damage from all these taxane and other chemotherapy. Patients who are on anti-hormone therapy like anastrozole or letrozole, those kind, or tamoxifen, they have side effects like joint pain and hot flashes and hyperlipidemia, blood pressure, those side effects. So yes, and because these treatments are like long-term, they get it for like 5 years, tamoxifen 10 years, osteopenia or osteoporosis, those, I remember you were talking about this. So these kind of side effects are long. And so I focus a lot on managing these symptoms. This is how I see it, because our patients are surviving, they are living longer, and yes, they say that I am a survivor, I have beaten this cancer, but the long-term impact from these side effects can be disruptive for their quality of life, right? Or prevent them from having a good, I would say, fulfilled life. Certain side effects like peripheral neuropathy. There I meet patients who still struggle with doing simple things like lifting tiny things from their with their fingers, or I have met a patient who failed to put the foot on the brake on time and landed up in a car accident. I have met a breast cancer patient who was drinking coffee, and because of the neuropathy, she spilled coffee on her chest and burned herself. I remember a lady who was climbing down the stairs, and because of neuropathy, she did not feel the floor and missed a step and fell down and landed up with fractures. So these kind of side effects, some can be long-term and disruptive, and so focusing on those, symptom management are becoming important now, because just treating the cancer is should not be the whole focus.
No,
I think
well, in nursing, we treat the whole person. Not medicine tends to focus in on what the issue is. We look at the issue, but we look at everything else too. We've got to take another break. So when we get back, we're going to continue on with this. I like getting Ranju's passion going. It's fun for me to see. All right, so don't go away. We'll be right back after a word from our sponsors. Hold on.
The following PSA is brought to you by UNC Health Nash, Boyce Willis Clinic, Primary Care Urgent Care, and WHIG TV. According to U.S. breast cancer statistics, 1 in 8 U.S. women will be diagnosed with invasive breast cancer in their lifetime. In 2025, an estimated 281,550 new cases of invasive breast cancer are expected to be diagnosed in women in the U.S., along with 49,290 new cases of non-invasive breast cancer. Early detection saves lives. Survivors know the importance of detecting it and treating it so you can defeat it. It's a journey that requires tremendous support. When was your last checkup? Beat the odds with regular checkups planned by you and your provider. Detect it, treat it, defeat it.
When Jay arrived at the emergency department with a hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough. I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't rise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
What is Celebrate Recovery? It's a Christ-centered, faith-based recovery program for anyone dealing with life's hurts, habits, and hang-ups. Celebrate Recovery meets every Thursday night at 7 p.m. at Farmington Heights Church in the Wilson, Raleigh, and surrounding areas. Please join us every Thursday night at 7 p.m.
All right, welcome back. This is Here's to Your Good Health. I'm Linda Prezioso, and I have Ranju Singh with me. She's a nurse practitioner at UNC Nash Cancer Center, and we've been talking about problems that patients get secondary to the chemo. So we've been talking about like nausea, for instance, that it's getting better, newer drugs to treat that. And I asked Ranju about symptoms, you know, what some of the symptoms, because I think sometimes we focus so much on the cancer treatment, we don't focus on other things happening in a patient's life. And we have to have a good quality of life as well as everything else. So,
100%.
Yeah. So, and you're passionate about, well, you mentioned something about vitamin D.
Oh, yes. So this was also my DNP project. I did a quality improvement project with my patients, breast cancer patients who were receiving paclitaxel, and we compared prospective data with some retrospective data for a couple of years after compiling them, and we found that patients who were deficient in vitamin D they had their neuropathy was severe, like they had chemotherapy-induced peripheral neuropathy, worse than people who were not deficient in vitamin D. So what I'm trying to say here is that when we treat a patient, there can be some other factors in them which can be causing discomfort to them, not just not just the chemotherapy. For example, patients who are already deficient in, for example, iron, right? So if they already have iron deficiency anemia, and you give them these chemo, which is causing myelosuppression, which can lead to further lower hemoglobin. And so yes, so sometimes treating these other factors when you are giving them chemotherapy becomes important too. So that happens a lot. We are giving them chemo, but we are also kind of deviating and checking their vitamin D level, their iron level, their B12 level, and fixing those. So I do see that managing these symptoms helps their cancer journey or chemotherapy journey manage in a better way, or I would say more comfortable. So these are the some symptom management which I actually like to take care of, or I would say make it as comfortable as possible for them.
Right, right.
Yeah.
And I guess they're going to come and just say, probably nobody's going to offer, oh, I have iron deficiency anemia. That's something you're going to have to figure out on your own. People don't.
Many times patients don't even know that they have iron deficiency anemia. They don't know that they have vitamin D deficiency, or so some of these are like found when they are getting treatment and we are giving them chemo, and for chemo we have to check their labs and do the we check for their CBC, which is complete blood count, and we also check for their liver function and kidney function. So many such findings are found around that time too.
I gotcha. Yeah. Is there? So I guess I would hope that it's not one size fits all. That each individual is, because Susie might not have the symptoms of fatigue or shortness of breath, but Naomi has this exact same treatment, and she does, but that's because everybody is different.
Yeah, so everyone's journey is different. I can tell you that patients handle the same treatment in so many different ways. Some patients, they just get through the treatment like this, but then there are certain patients who land up in the ER at least 2-3 times during their cancer journey. So yes, your baseline health status matters. How you are managing your symptoms matters. Supportive system, like support system at home, that also matters.
Sure.
And I do see that patients who have good support system, like friends or family or relatives or neighbors who are good at providing them care. But when I mean care, not just like bringing them to the clinic, but also other things too, like they are there when they need them. Those patients tend to do better than patients who are on their own.
I guess that's one of the reasons why I like being a nurse practitioner. I like mysteries. I like to figure things out. And so for me in the clinic, they can come in saying one thing, but really it's a whole nother ball
that happens so many times. Yes.
They do the same thing in this cancer center. Yeah. And I know in the past I've had volunteers that have come and shared their participation in taking care of your patients. And do they still have a big volunteer group that comes?
We do, yes. UNC Nash does have a big volunteer group.
And I would think that would be a benefit for the patients as well.
Yes, it does. I think we have scope to have more volunteers, but yes, it is helpful for them.
And I think I've noticed, attitude is 100% too. if you're kind of a poor, pitiful me, I've got breast cancer, oh, woe is me, you're probably not going to do as well as, you know, if the glass is half empty versus half full.
I agree. Yeah.
Yeah.
So this is how I see it. We cannot control. I think we cannot control how long we are going to live.
That's right.
There are certain things which are out of our hand, but while we are alive, we can control how we live. How
Right.
we live that life, right? We can see it as a glass half full, or we can see glass half empty.
Correct.
That kind of philosophy. So yes, positive attitude does help
Right.
in better recovery,
Right.
I would say.
Right.
And yeah.
So if I suspect somebody has cancer, it's not breast cancer, I don't have a mammogram, I can just refer over there as a provider, or how does that work?
Yeah. So you can send them to Nash Cancer Center, and if we have confirmed biopsy, that's the best. If you don't have a confirmed biopsy, you are just suspecting that it could be cancerous. Sometimes that can also be, that also works, that can be sent. But it is better if you have a...
We already know
yeah,
there's a diagnosis.
Okay, so yeah, if you already know and you have a diagnosis, or tissue diagnosis, I mean, then you can, yeah.
Okay.
Yeah.
And do you personally treat the hematology? That's blood. The hematology means
Yes, yeah.
study of blood. Do you treat those patients too?
Yes, we do, and it is interesting, and sometimes I do see that some patients who come there for heme problem, like just anemia, they don't have any oncology or cancer related problem, they see hematology, oncology, and they think that, oh, now they have cancer, and they freak out, and they come to me and they're like, so do I have cancer? Why I'm sent here? And I had to convince them like so many times that no, you don't have cancer,
Right.
you don't have blood cancer, but you do have a blood problem.
Right.
Like your hemoglobin is low, or these kind of, or your platelets are low, or your white blood cells are low. So you are here for heme problem, but that doesn't mean you have
I
cancer.
have cancer.
And I think pretty much all over United States we have heme and oncology clinics are, like, especially in the general practice, are together. So yes, so we do see hematology patients, non-cancerous ones, and I do see new consults, and nurse practitioners there see new consults too. New oncology patients goes to our MDs, our medical doctors, and once they establish the treatment plan for them, then we take over from them. We try to rotate our patients, like between NPs and MDs, oncology patient, but sometimes it's hard because it's limited. Yeah.
Yeah, so we've only got a minute or so left, so do you want to recap things you want the clients here,
Yes,
the audience to know?
Definitely, yes. And thank you for giving me this opportunity. I know this is the second year of
Oh yeah, we
this
got to
talk.
do this every year.
Yes.
I just love her. She's great.
Thank you for saying that. Yes, so get screened. Do your mammogram. If 40 plus and above, 40 and above, definitely get it done. Or if you have family history where someone was diagnosed at the age of 40 or 45, then you can start at 30, right, 10 years before that. And self-breast examination once a month, 7 to 8 days or 1 week after your periods are a good thing. Not all painful thing in your breast is breast cancer, so do not worry about that. But yes, if you ever found if you find a change in your breast tissue, or any orange kind of skin, or retracted nipple, or there's a lump, or there's a discharge, or there's a blood, anything like that, anything suspicious, go get yourself examined and get it seen. More and more younger patients are getting breast cancer. And second thing, first was screening, and second, I put more and more importance is healthy lifestyle, eating right, maintaining your weight, cutting down on carbs, eating more fruits and vegetables, exercising. These are some of the stuff. Staying happy, enjoy. I know, staying happy is so important. Staying happy and taking care of yourself, good rest, and less alcohol, less. Or you can say no alcohol or no to smoking, those kind of
let's not smoke.
Yeah, exercise. And these are, so with these lifestyle changes, modifications in your diet, it would give you better chance of, I would say, defeating any kind of, not just breast cancer, any kind of cancer or any kind of health disease.
That's right. Any
health
kind.
problem, yeah, any kind. So do that. So that was my second, and stay happy.
That's right, stay happy. Yeah. Well, it's time for us to say goodnight. Thank you so much. Thank you, Ranju, for coming.
Thank you, Linda, for having me here.
So yeah, she rocks. What can I say?
I enjoy talking to you, and you're wonderful. So yeah, thank you.
All right, now that we've each sung each other's praises, we're going to say goodnight. We'll see you next week with more of Here's to Your Good Health. Have a good night. Bye-bye.
Thank you. Good night. Okay.